Hello, my name is Eric Secemsky. I'm the Director of Vascular Intervention at Beth Israel Deaconess Medical Center in Boston, Massachusetts. I'm joined here with Michael Siah, a wonderful vascular surgeon at UT Southwestern in Dallas, Texas. And today we'll be talking about the value of shockwave intravascular lithotripsy for peripheral vascular intervention. Michael, thank you very much for joining me in this conversation.
It's great to be here with you.
So we have a nice conversation to start about some tricks and techniques for using intravascular lithotripsy, and then we'll move through 4 cases where this therapy has been particularly effective in improving our outcomes and technical success of our lower extremity interventions. So, Michael, first question for you. I think one thing that has always plagued me, and we've talked about this before, is undersizing of devices. And we know that this is a common pattern, and people can get away with it with a plain old balloon and deal with a small lumen. Maybe that's not what's best for the patient or the outcome, but we know with a therapy like intravascular lithotripsy, that can really detriment the outcome and the effectiveness of the device. So what do you think is a natural tendency? Like, why are people prone to undersizing and inappropriately sizing?
Yeah, I think it just goes hand in hand with the pitfalls or shortcomings of conventional angioplasty. If you oversize a balloon, you're more likely to cause a dissection or, heaven forbid, even perforate an artery. So most people, I think, will undersize to mitigate those risks. But at the same time, like you said, you're not going to get the most durable or best outcome for your patient. And especially in patients who have wounds, optimizing lumen gain is critical to get wounds to heal.
Absolutely. Yeah, it's interesting. If you look at some of the data on this, there's a study that looked at the differences in measuring vessel diameter through different modalities. And I always quiz the trainees of, what do you think this anterior artery diameter is? And they'll say, there's a chart in the room, they'll say 2 millimeters. And I say, okay, well, let's look on IVUS and size it, and it'll be 4.5 millimeter vessel. And I think our teaching was always inaccurate in terms of the algorithm of every vessel is only a certain range of size, irrespective of the patient. But also we saw on these studies that if you compare digital subtraction angiography to a device like intravascular ultrasound, on average for a tibial vessel, you're undersized by about a millimeter. And thinking about that, if you're going to take a technology like intravascular ultrasound and it says it's a 4 millimeter vessel instead of a 3, are you so comfortable going to 4?
Oh, absolutely. Absolutely. And I do the same thing with my trainees. One of my favorite things to do is we cross our lesion, we take our pictures, we've identified what we want to treat, and you ask them, what do you want to use? And they undersize the balloon. I was like, okay, open the IVUS. This is a great opportunity for you to see how wrong you are.
Yeah.
And it's pretty interesting to see how quick people change their sizing algorithm, even the trainees, after they see you, after a couple of cases doing that same thing that you do, they historically were undersizing things. Yeah. And everyone's got the same chart, outside the lab or in the lab that shows like a tibial is anywhere from 2 to 3 millimeters and SFA is no bigger than 6.
Exactly.
But we know that that's way off from what we really see on a day-to-day practice.
Exactly. I knew I liked you for a reason. Yeah, I think that, I think that's a real issue. And when you think about all the failed interventions and devices for below the knee space, I truly think a lot of it is related to undersizing. And if you think about even delivering drug, just like IBL, it only works if you're touching the vessel wall. And so you really can't appreciate that on an angiogram. Sometimes you can see that it's touching in one segment, but you can even try, sometimes I'll shoot contrast just to see how much contrast moves through the vessel to show that there are potentially areas where not really approximating the vessel wall just to prove a point. And
it's a poor man's IVUS.
There's a poor man's IVUS.
Poor man's IVUS.
Right. Absolutely. So, I think for myself, and I've spoken a lot about this the last several years, IVUS has been a really important part of my algorithmic treatment approach for lower extremity intervention. And, I think of it for many reasons. I like the idea of understanding exactly why I'm choosing a device and for what reason. And one area that really bothered me was that you can't really appreciate calcific burden for infrainguinal vessels, and particularly with the CTO. You don't really have you don't have the contrast, you don't have a great definition of the vessel wall. And so now you're really doing some guesswork in terms of what the right therapy is. Have you ever noticed that your kind of estimate of the calcific burden changes when you use IVUS versus just an angiogram or even a CT scan or other imaging modality?
So definitely below the knee. The calcium burden we face on a day-to-day basis is significant and severe, and you truly get a sense of that when you use IVUS, right? I mean, you look angiographically and you shoot a picture, and it doesn't look like the vessel is calcified at all, but we know, in diabetic patients, they have an extensive calcific burden. You see that every single time, that 360-degree calcium burden that on an angiogram looks like it's non-calcified. So it's really opened my eyes to that burden of disease. And, it also probably lends a little bit of insight into the fact that conventional angioplasty hasn't borne out the outcomes that we wish or aspire for it to have, which is why we need to look at other technologies.
Yeah, great comment. And I think, again, there is the importance of identifying concentric, even any type of luminal calcification, but also the prevalence of medial artery calcification and more deeper calcification. And there's only a few therapies that can really address both types of calcific burden. We have really most of our atherectomy devices are geared towards luminal disease, so that intimal calcification, but it's not going to change the compliance of a vessel that has deeper calcium that we recognize on an angiogram. You see in an IVUS, and really you need specific technology to address that deeper calcific burden. If you think about the penetration of IVUS in the peripheral vascular space, I'd like to, promote that I think that it has been increasing, but traditionally it's very low. And, we sit up here coming from two different training backgrounds, and when I do coronary procedures, we wear it as a badge of honor when IVUS is used as part of a coronary procedure. We consider that as you're not being lazy, you're doing what's best for the patient. And we try to get our numbers in our lab more than 70% imaging. Whereas we know in the periphery, it's less than 20%. And it can change by where you practice. Maybe that 20% is the average for everybody across the U.S., but that's really only a select number of operators who are doing a large number of IVUS images. So, if you think about where barriers lie right now in terms of IVUS utilization, how would you kind of think about it? Like, what do you think are the main limitations right now?
I think it's multifactorial. I work in a large academic institution in the hospital, and I think one of the reasons why people have been hesitant, at least in my practice environment, to adopt it is not only does it add a little bit of time to the cases, and we're always struggling to, we've got 5 or 6 cases in a day and you got to get them all in. You're adding another step. The nurses have to go get the device. We have to set it up. We have to make sure the catheter works. I think some people think of it as a burden in spite of the benefits that it may have on outcomes. And then additionally, there's obviously the cost piece, right? I think every institution is thinking about cost, and at least in the hospital, reimbursement isn't the same as it is in other environments. So it's adding to the burden that we're dealing with in healthcare systems and taking care of these really complex patients. But despite that, I think it's a great tool, not only for my patients, but, just for training people. And I think the more people that embrace that sort of perspective will lead to increased adoption or more widespread adoption of IVUS.
Yeah, those are great comments. I think that's how I think about it as well. There's always this argument of, I think about it in bins of the evidence supporting it, the practicality of using it, and then the ability to interpret it.
Yeah.
And, there was so much comments when we first talking about peripheral IVUS about the evidence, and we've really seen a growth of evidence supporting its use. Randomized trial came out last year. We've had a lot of observational studies. We have a consensus document now. But thinking about how do you prepare your procedure and streamline your procedure. And in my lab, what we typically do now is I think most everyone in the lab knows that IVUS is going to be part of my procedure. So the console's there, the catheter's pulled, and so when I go to reach for IVUS is now part of that algorithmic approach, just like an ultrasound would be for getting access. It's there, it's prepped. I do the same thing when I get groin access. It's always under ultrasound, and that is prepped and ready to go. I do the same thing with IVUS. And then the other thing that I think saves time is you get comfortable with IVUS, and you pull back the catheter, you're making decisions actively at the same time. And so you could plug the device in, or you could prep the PIM and put it on the table, press the button, or you pull it back, and you're ready already to say, listen, I got a little bit of understanding of sizing just from looking at the dots across the screen. I know if I have calcium or not. Am I going to do shockwave? I'm going to do another device. Is there thrombus? What's healthy? What's not healthy? And I've got all that information in a run. And so I do think that probably you've seen this in your practice, a certain number of cases and a certain routine ends up taking away a lot of that burden of the time addition to that procedure. Any thoughts on that and with their trainees?
No, I completely agree. I think the more you use any technology, the more comfortable people in your lab feel about using technologies, the easier it becomes, right? And I think with frequency of use comes that understanding you're talking about. And I think that can ultimately shave down on your procedural times because you're not hemming and hawing and you're making more educated decisions. But just from a more global or larger perspective, I think some of the hesitancy has been in dealing with those challenges of starting that program, of understanding how to use it. But there's no doubt that it helps.
Yeah, and we did this on the coronary space with some other imaging technology, and we went through this program where you were an early user to a more advanced user. And what happened during that pathway is you actually ended up saving time, even from your baseline when you weren't using imaging, when you incorporated your procedure, and also used less radiation, less contrast, and one less device. So one less balloon because you were sizing more appropriately. So I think there is this learning curve, as you mentioned, that you get to the point where you can actually make your procedure as, if not more efficient, but it has to be practiced just like anything else we do. Just like getting access. We know we can waste the time to do an IVUS run hemming and hawing about the access and dilating up and everything and not having enough nick and spread to be able to get sheath in, and then you already got your time back for your IVUS catheter if you do that right. So yeah, I think that's a great point.